So welcome to the 2021 Forum on Aging in Rural Oregon virtual series this year. My name is Rose Locklear, and I am the host of the Forum on Aging at the Oregon Office of Rural Health. And I wanted to remind you all, we took last month off, but we're here this Thursday and next Thursday with 2 sessions this month in June. And these sessions will continue to occur every third Thursday from 2 to 3 p.m. We do plan to be back in person in 2022, so look out for that notice. Before we jump into the particulars of this, I want to make sure to call special attention to our partners this year, GOBI, Central Oregon Health Council, as well as the Older Adult Behavioral Health Initiative. Without our partners, we would not be here today, so thank you so much. Next slide, please. So we have Nirmala Dhar joining us today, and Nirmala has no conflicts of interest to disclose. Next slide. And the orientation. So I know we're all using different platforms these days, but we are on WebEx today, and you have a ability to, well, actually you're all muted and your video is turned off as attendees. If you want to communicate with us, as we kind of started figuring out the chat function today, seems like you've all located that by the ellipses down at the bottom of your screen to the far right. That'll populate the chat feature to your right. Since that scrolls kind of continuously with whatever information y'all are putting in there, please use the Q&A function, which is also actually is in the ellipses. Now WebEx keeps updating and changing things around on us, so it's the Q&A function that's going to be in those ellipses to your right. If you select it, it'll populate, but please ask your questions using Q&A so I don't lose track of them. This session is being recorded, so hop off now if you have any issues with that. The slides and this recording will be available at the Oregon Offices of Rural Health Forum on Aging website. And if you'd like continuing education unit credits, I will put a survey link in the chat function at the end of the session. We'll also send that out to all the folks that are on right now, so please do complete that if you'd like to receive the credits. Next slide, please. All right, and that brings us to Nirmala. Nirmala, thank you so much for joining us today. I'll just let you go ahead and get started. Nirmala is going to talk to us about, let's talk about dementia. She joins us as the Older Adult Behavioral Health Project Director at the Oregon Health Authority, and I will let Nirmala take it from here. Thank you so much.
Thank you so much for the invitation, and I'm delighted to be here, and I'm really delighted to see, I saw the list of registrants. We have a great variety of professionals and community adults attending today. So I'm thrilled that so many of you are coming here today to really learn more about dementia. So thank you for being here. And I asked Rose to put that question in the chat. If you can just very briefly tell me in the chat box what are you looking for from this training today? And I don't know, either Rosalie or Eric, if you can just read me like three or four of those, so it would kind of inform where I would kind of then focus on if I can. I know this is only 1 hour and we have a lot to cover, so.
Yeah, so we've got, overall the general consensus just is kind of a general what to do about your elderly patients, resources for elderly patients,
Okay.
Individuals with family members that have Alzheimer's or dementia, how to serve best their older adult populations coming from community level.
Okay, well, thank you. So, Rosa, if you want to put my PowerPoint on and just move to the second slide, so I can tell people what my talk is going to focus on today would be that you will understand what are symptoms of Alzheimer's disease and other dementias. You will get knowledge in how caregivers are impacted by taking care of someone with dementia. Then we're going to look at why people with individuals with dementia are at particular risk for elder abuse. And then lastly, we are going to spend a chunk of our time looking at what are the resources that are available to you all as professionals and as families. So that's kind of the gist of my topic today. And I recognize a lot of you on the training. So hi, everyone who knows me. I'm delighted that you're here. Next slide. So let's start with kind of, what is the basics? It's a brain disease. It's progressive. It's irreversible. If it is real, genuine dementia, it's irreversible. Currently, there is no cure for it. And it is in the top leading causes of death in the United States. Um, and sadly, it is one of those top 10 which really has no clear cure for the disease. I know there is cardiovascular disease and cancer is, up there, but they have very effective therapeutics for both those, for those disease states, but we don't have anything for dementia as yet, which is what I'm referring to is like disease modifying drugs. I know there's a new drug come out like yesterday or maybe the day before, which I'm still, I don't know much about, but overall, there is really no drug which actually can cure dementia. Next slide. And this slide that I want to show you really demonstrates, oh, maybe I didn't send that. That's okay. So what are the facts and figures? Over 6 million Americans age 65 and older are living with Alzheimer's dementia in 2021, 6.2 million. More than 1 in 9 people have this diagnosis, or older Americans. 2/3 of these are women. That means, close to 4 million of the 6.2 are women. Deaths due to Alzheimer's between 2000 and 2019 more than doubled. And so currently 1 in 3 seniors dies from Alzheimer's or some other dementia. Next slide. And maybe I did not send this additional slide, but I'm just going to tell you what is the Oregon statistics. In 2020, that is last year, we had 69,000 Oregonians with Alzheimer's disease or another dementia. And by 2025, which is a short 4 years away, it will reach 84,000 Oregonians, which is a 22% increase from 2020 to 25. So just remember that 69,000 Oregonians, and in 4 years, that number will be up to 84,000. Then look at this. While deaths from Alzheimer's disease have increased, remember I told you they've increased between 2000 and 2019, in that same time period, deaths from heart disease have decreased over 7%. Alzheimer's disease and other dementias kill more people than breast cancer and prostate cancer combined. Discrimination is a barrier to Alzheimer's and dementia care. And this population reports discrimination when seeking health care. 50% of African Americans and 42% of Native Americans report that. And Alzheimer's and dementia deaths have increased 16% during this pandemic. And these figures, I have my citation at the end. Most of the prevalence data is coming out of this latest study from Alzheimer's Association, and you will find the resource at the end in my resource section of my presentation. Next slide. So what's the difference between this prevalence, this gender difference between men and women? More women than men have Alzheimer's and other dementias. Almost 2/3 of Americans who are living with dementia are women. I told you 3.8 million. These differences may be based on a combination of chromosomal or hormonal differences, which are sex differences, or differences in the environment, social and cultural influences on men and women, or a combination of both. So we really don't have a very clear understanding of why is it that, mostly it is women, 3.8 million of those 6 million are women. And so there's lots of research being done, but these are all the kind of areas of research, whether it's biology, environment, social, cultural, or a combination of both. But suffices to say for our information today, yes, there is a gender difference in Alzheimer's disease and dementia. Next slide. Now look at race, and ethnicity. Whites make up the majority of over the 6 million people with Alzheimer's disease, but combining evidence from various studies, it shows that African American and Hispanics are at higher risk. African Americans are about 2 times more likely than white Americans to have Alzheimer's or other dementias. And Hispanics are about 1.5 times more likely than whites to have Alzheimer's and other dementias. So let that kind of sink in. So there is a disparity here. And the risk is higher for these two groups. Next slide. And look at what this leads to in terms of disparities. While African Americans are about 2 times, I just told you, more likely than whites to have Alzheimer's disease and other dementias, they're only about 34% more likely to have a diagnosis. That means, just look at it, 34% more likely. And Hispanics are about 1.5 times more likely than whites to have a dementia, but they are only 18% more likely to be diagnosed. Can you see how these inequities result in disparities? Next slide. And look at this next slide, under diagnosis of Alzheimer's and other dementias in primary care settings, because that is where most older adults go. They don't go to a neurologist, they don't go to a psychiatrist. They see their family doctor or their family provider, whether it's a nurse practitioner or a physician's assistant. Well, guess what? It's underdiagnosed in primary care settings. Since 2011, remember, the Medicare instituted this annual wellness visit, was included. And in that wellness visit, there's cognitive evaluation. And by the way, this is free to the Medicare member, no copay for this wellness visit. And a survey from Alzheimer's Association found that only 1 in 3 older adults were aware about these visits and that they could ask for a cognitive assessment. So all of you on this training today, if you work in community settings or in the community, let this fact be known to your older adults that they can ask for this wellness visit and particularly ask for a cognitive evaluation free with no copay. Further, while 82% of older adults believe it is important to have their memory and thinking checked, only 16% reported having any of memory and thinking checked by their primary care provider. Only 16%. And remember, this wellness visit has been in effect for 10 years. Only most older adults, almost all, 93%, said they trust their doctor to recommend testing for memory. However, 94% of primary care providers, physicians mainly, stated that it was important to assess older adults' cognitive impairment, and fewer than half say that it is part of their standard protocol, these primary care physicians. And the main reason, the patient presents with no symptoms or complaints, so we don't do it, or lack of time. That's what drives this kind of underdiagnosis. Next slide. And so why am I talking in particular about primary care? Often, first to address a patient's complaint or family concerns about memory care, because that's where you go. You'll talk to your family doctor or your family nurse practitioner. With the use of cognitive screening tools, you can identify emerging cognitive impairment, possible causes, follow up with treatment if it is a reversible condition, or if dementia is found, that you can help your patient and the caregiver prepare for the future. And that's why I'm talking about primary care, especially in rural settings. This is a rural health forum. So here are some good, simple questions to ask in primary care. Next slide. About memory and cognition. Are you worried about your memory? Have you noticed a change in your memory that concerns you? During the past few months, have you had increasing problems with your memory? Anyone on the primary care team can ask these questions to an older adult who's coming in. Remember, one of the reasons why it's underdiagnosed, they're saying the patient never asked us. How about we asking the patient? Next slide. And here I'm giving you some other opportunities for screening. When someone presents with a concern for the Medicare wellness visit, they have increased risk for cognitive impairment. For example, if they have the presence of vascular risk factors, and they are middle-aged and have a family history of it. So that's an opportunity to screen. And if they have significant medical comorbidities which are associated with high risk for cognitive impairment, such as brain injury, sleep apnea, any kind of psychiatric diagnosis, especially like serious mental illness and metabolic conditions, which includes things like diabetes. So those are opportunities for you to screen. Next slide. And what is the benefit for early detection? Better chance from benefiting from treatment, more time to plan for the future for the person, your patient, and for the caregiver and family, lessened anxiety about unknown problems instead of wondering what's happening to me, increased chance of maybe participating in clinical drug trials or some other kind of advanced research, an opportunity to participate in decisions about care, where you would like to be, about living options, about legal matters, while you still are in the early stages, and then benefit from care and support services, making it easier for your family caregivers to understand the disease and know how to support you at home. So those are really the benefits of early detection. Next slide. And, I always get questions, Nirmala, what's the difference between normal aging and dementia? I forgot where my car keys were the other day. Am I getting dementia? In normal aging, for the most part, your independence is preserved. When you have a progressive disease like dementia, you do get dependent on others for your living activities. I'm not going to go through this entire list because of a lack of, I need to be cognizant of time, but look at on normal aging does not get lost in familiar places, while in dementia gets frequently lost in familiar areas, even in a neighborhood where, you've lived for many years. So I'm going to leave it for you to take a look at this when you get my PowerPoint slide deck. Next slide. So I just want to touch very briefly. I just have a couple of slides on DSM-5 because I know some of you are, practicing perhaps in the behavioral health field or elsewhere. So the DSM-5, which is the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders. The name has been changed from dementia to neurocognitive disorder. And what I wanted to highlight was how it is defined. Decline from a previous level of functioning. Previous level of functioning in one or more of these domains. Your executive abilities, which is your abilities to plan, to organize, to self-regulate, to start and persevere on goals, to really look at inhibition. All of those are executive functions. Your language ability, which is really cognitive language, learning and memory, perceptual motor, social cognition, and attention. So you have to have a decline in any one of these 6 domains from a previous level of functioning to be diagnosed with kind of a neurocognitive disorder or a dementia. Next slide. And then part of that, partly in addition, that decline has to interfere with independence in everyday activities for it to rise to the level of a diagnosis. These deficits do not appear in the context of a delirium, and they're not explained, and they cannot be explained by any other mental disorder. Okay. Like depression or schizophrenia. Sometimes, they also have issues with attention and memory. So you have to rule that out and then decide, no, this is really a neurocognitive disorder. Next slide. And so really neurocognitive disorder or dementia is an umbrella term. So dementia is not a single disease. It's an overall term like heart disease or cancer that covers a wide range of very specific medical conditions, one of which is Alzheimer's disease. And there are many other kinds of dementias who all have very different pathogenesis or etiology. For example, the leading one in the United States is Alzheimer's disease. But then we also have Lewy body dementia, which is different, vascular dementia, we have frontotemporal dementia, and many others like Parkinson's disease dementia, Huntington's disease. So again, remember, and there's also mixed dementias where you can have, 2 dementias. But so for suffices to say, for you to remember, it is an umbrella term. So it's not a single disease. Next slide. So just because Alzheimer's disease is the most common in the United States, so I just wanted to again reiterate that it is a brain disease, just as coronary artery disease is a type of heart disease. Again, it is progressive, meaning that it gets worse over time. So it progresses from mild to moderate to severe. So it gets worse. Its trajectory is kind of a downward slide. And Alzheimer's disease is thought to begin actually 20 years before actual symptoms arise. 20 years before that. It starts with changes in the brain that are unnoticeable. Only after years of brain changes does the individual experience noticeable symptoms such as memory loss and language problems. And we are going to look at those. So for our purposes, it really begins 20 years before you begin to see symptoms, actual symptoms that impact functioning. Next slide. So here are some of the brain functions that are affected. Somehow I think I forgot to send some of my additional slides. So I'm just going to quickly go over them and then tackle this slide here. So some of the brain functions that are affected are memory and learning, language, attention, judgment, reasoning, speed of processing, visual, perceptual, motor functioning, and then executive functioning. And so how do these signs and symptoms look like in dementia? We all know about memory and memory loss, but it is memory loss that disrupts your daily life. And this is one of the most common symptoms. Especially forgetting recently learned information. These include forgetting important dates or events, asking for information over and over again. So, they keep asking because it's not sticking, they cannot store it. More importantly, they can't retrieve it when they need to use it. Sometimes they may need to rely on memory aids for family members for things that used to be handled on their own. For example, taking their medications, following some kind of a medical regimen, or remembering to use an appliance in the kitchen. So it is memory loss that disrupts daily life. Challenges in planning and problem solving. So it becomes a mystery in terms of simple problem solving tasks. They may have trouble following a recipe to make a meal, which they have done for years, but now they cannot. Keeping track of monthly bills on, how to when and how to pay them, or also making change, when you go to shop. They may have difficulty concentrating, and they may take much longer to do simple tasks, which in the past they could do, in a jiffy. Remember, I said it is a decline from a previous level of functioning. Then difficulty completing familiar tasks at home, at work, or at leisure. You may have trouble driving because you get lost. You don't know which location you're heading. You may not be able to work on a budget. You may not be able to remember the rules of a favorite game, or a card game. And so you no longer can do those familiar things. Next slide. Confusion with time and place. You're disoriented to date, time, seasons, and you may have trouble understanding something if it's not happening in real time. And sometimes, they may forget who they are and where they're going. We often hear of stories where people are confused and lost and, and wandering and are found by either law enforcement or someone else. It's that confusion of time and place. Trouble understanding visual images and spatial relationships. They have problems with judgment, judging distance, determining color or contrast. And this can cause problems with driving, and so all of that gets included in this. Very important, they may have problems with finding words and in speaking and writing. Remember, I talked about language, or cognitive language. In fact, those are some of the very early signs of dementia, when a person has a hard time finding the appropriate word, or they may start reducing how much they talk or holding a conversation because they're struggling with vocabulary. For example, I've got an example calling a watch, a wristwatch, a hand clock, because they can't remember the word wristwatch. And I'm going to give you some screening tools at the end, where one of them is language fluency. Next slide. Misplaced things and losing the ability to retrace your steps. Remember, many people tell me, Nirmala, I parked my car the other day in the garage and it took me 10 minutes to find my car. Am I getting dementia? Most of us can then retrace our steps and find the car, even though it may take us longer. But someone with dementia, it's just lost. They're unable to retrace their steps and find whatever they're looking for. Sometimes they can accuse others of stealing something which they have misplaced. And then decreased judgment. You may find they're experiencing changes in judgment or decision making. For example, judgment in dealing with their money, or they could be giving away large amounts of money to con artists or telemarketers because they no longer have that ability to judge. Is this a good investment? No, or is he trying to con me? That's kind of lost. Or they may pay less attention to grooming or hygiene, or they may actually be sexually and socially inappropriate because of impaired judgment. Next slide. A lot of withdrawal from work and social activities, especially early on when they realize that something is the matter, they can't think clearly, so they may start avoiding social activities. And then also big changes in mood and personality. They could be confused, they could be suspicious, they could be depressed or fearful and anxious. All of those kind of accompany dementia, especially as it progresses. So next slide. And I like this graphic of mine. It is the picture of a stool. Next slide. And I really look at dementia as 3 legs of a stool. So it affects your cognition. It affects your daily functioning. That means real life functioning in the real world. and it can affect or your behavior. That means you can see behavior changes. So it affects all three areas, not just cognition. Next slide. So how does it affect your functioning? We talk about these two kinds of functional impairments. One is what we call instrumental activities of daily living, and the other one we call activities of daily living. And what are these? Next slide. Initially, when you get diagnosed, these are the activities which get affected, instrumental activities. They are those higher level of independent living activities, and these require what I call more cognitive bandwidth to function independently, like shopping, cooking, budgeting, managing your medication or complex health condition, knowing how to use the phone or the internet, especially in emergencies, maintaining your house and housework, driving or being able to access public transportation to get your needs met, managing your finances, like paying your bills on time, having a budget, all of that. These are called instrumental activities, and they get affected first. Then they are followed next by activities of daily living, which are your what sometimes also, next slide, referred to as basic activities of daily living, such as bathing, dressing, grooming, oral care, toileting, uh, cleansing, cleansing after toileting, transferring, walking. So you can see all of that. Those are the second set of activities which get affected. When I talk about function, this is what we are looking at. Next slide. And then we have another set of symptoms which also develop called neuropsychiatric symptoms. And they're almost universal in dementia. And these symptoms cause caregivers a lot of, increases their burden. And it impacts both the caregiver's quality of life and the person with dementia. And generally, these are what we call like psychotic symptoms in dementia. And they're across the board in all the different kinds of dementias. But some dementias, you see them more than others. For example, if you can see here, Lewy body and Parkinson's have more of these psychotic symptoms. Next slide. And what are these psychotic symptoms? One is hallucinations, which are, by the way, not schizophrenia or bipolar disorder. This is because of dementia. And what are hallucinations? They are perceptual experience that occur without any kind of external or sensory stimuli. So they could be visual. They could be, they affect all of your senses. For example, you may see things, you may hear voices, or you can have delusions, which are fixed false beliefs. Someone is stealing my things, or my caregiver is coming into my room and taking my jewelry, or someone visual or common is, oh, I can see my parents from the corner of my eyes, or I can see a cat in my kitchen every day. So these are common neuropsychiatric symptoms. Next slide. And the burden of this often falls on caregivers, to make sense of this. Common delusions that target family members. You're stealing my things. You're going to abandon me. You're not my spouse. You're an imposter. Or you're having an affair. You're accusing your spouse, who's your caregiver, you're having an affair. So can you see, this causes a huge amount of burden for caregivers. Next slide. So so we talk about these challenging behaviors in dementia, and we always talk about looking at non-medication approaches should always be like a first line approach to these behaviors. And that our philosophy should be that behavior is really an expression of an unmet need. What is my family member trying to tell me in this behavior? what is being communicated, or what is my nursing home resident telling me through this behavior. So I just wanted to, we teach a whole class on this, but I just wanted to kind of lay that framework for you. Next slide. And this really is a hot off the press from Alzheimer's Association, which is what should our practice look like, for people with dementia, wherever you serve. Person-centered focus. And if you can look, it begins with that gray bubble right at the top: detection and diagnosis, assessment and care planning, medical management, information, education and support, ongoing care, appropriate staffing wherever the individual lives, therapeutic environment and safety, and transition and coordination of services. And again, my links are at the end, so you can actually download this. But again, this is what is recommended as best practice for a person-centered focus. Next slide. So I want to shift gears and move to caregivers. Approximately 2/3 of dementia caregivers are women. 30% are age 65 or older. That means a third of them, of these women who are providing care, are older themselves. And 60% of caregivers are married, living with a partner, or are in a long-term relationship. Next slide. The responsibility of caring for someone with dementia falls to women. It is often daughters, daughter-in-laws, an aging spouse who is a wife, and also our caregiving sector is also dominated by women. As mentioned earlier, approximately 2/3 of dementia caregivers are women, whether it's paid or family. Over 1/3 are daughters. It is more common for wives to provide informal care for a husband than vice versa. And this is coming out of that report from that you will see my link at the end, from Alzheimer's Association 2021 report. On average, female caregivers spend more time caregiving than male caregivers. The bottom line, it is a female-dominated world for in terms of caregiving, whether it is professional paid or family caregivers. And here is my next slide, my caregiver Bill of Rights. I'm not going to go over it, but all of you who work with caregivers, please print this and give it to them. Give it to family caregivers, or have a group and discuss it. Because of time, I'm not going to go over it, but I wanted to include it. Next slide. Look at the health and economic impacts of caregiving. As the person with dementia symptoms worsen, remember I said it's progressive, caregivers experience increased emotional stress and depression, new or exacerbated health conditions that they already have, depleted income and finances due to disruptions in employment. Remember I said 1/3, I said maybe 2/3 are daughters who are working, and in employment and paying for healthcare or other services for themselves or the people living with dementia. And so they did a meta-analysis, reported that caregivers of people with dementia were significantly more likely to experience depression, anxiety than non-caregivers. Dementia caregivers also indicate more depression symptoms than non-dementia caregivers. That means you can be a caregiver of another kind, someone else who has some other disability. But if you're taking care of someone with dementia, you're more likely to have depression. The prevalence of depression is higher among dementia caregivers than any other caregivers. And the chronic stress of caregiving is associated with increased incidence of hypertension. And guess what? Hypertension is a risk factor for cardiovascular disease and death. You remember that's the leading cause of death in the United States. Next slide. Look at in Oregon, the percentage of caregivers reporting depression is 20%. More than half report one chronic condition. And remember, I said chronic conditions get worse with caregiving. And about 17% report frequent poor physical health. Next slide. So it's a huge issue. Health care utilization by caregivers. Increased depression symptoms among caregivers over time are linked to more frequent doctor visits, increased outpatient tests and procedure, and greater use of over-the-counter and prescription medication. That means the caregivers are at high risk for poor health and poor mental health. And by the way, COVID-19 and all of the social mitigation strategies really impacted caregivers, especially dementia caregivers, family caregivers. Next slide. And look at racial ethnic impacts on caregivers. Among non-white caregivers, half or more say that they face discrimination when navigating the healthcare setting for their family member or the care recipient, with the top concern being that providers or staff do not listen to them because of they perceive it because of their race, color, or ethnicity. 2 out of 5 caregivers who provide unpaid care to a Black person say that race makes it harder for them to get excellent health care. And 1 in 3 caregivers of Hispanic origin say the same. So what are some interventions, next slide, for caregivers? For all of you who work in this field, providing case management, information, referrals, coordination, providing state-of-the-art psychoeducation to these caregivers, making counseling available, making it really low barrier for family members who are providing caregiving. Next slide. Really having some kind of respite program. And I'm going to share resources with you. Provide planned temporary relief for the caregiver through the provision of substitute care. Examples include adult day services, in-home or institutional respite for a certain number of days or weeks. And then, of course, support groups, which are less structured than psychoeducational or therapeutic interventions. These are really support from your peers. Okay, so my next few slides, I'm trying to look at my time. Next slide. I'm really talking about elder abuse, and I'm not going to spend a great deal of our time on it, but there is no excuse for elder abuse. Elder abuse includes physical, sexual, psychological, verbal, as well as neglect, abandonment, financial exploitation of an older person by another person or entity. By the way, it can occur in any setting, in your own home, even in a licensed facility. And very sadly, it occurs in a relationship where there is an expectation of trust, or when a person is targeted because of their age or disability. And like I said, multiple forms of abuse exist. Next slide. And look at it. 1 in 10 seniors is abused every year. 1 in 10. And we think that is dramatically underreported. And cognitive decline, like dementia, is a risk factor for abuse of all kinds, including financial exploitation. Next slide. Look at in the emergency room. This is abuse is missed in the ER. In 2017, in a nationally representative sample, only about 0.01% of older adults presenting to the US are formally received an elder abuse diagnosis. Further, they generally ask only one question in triage: are you safe at home? That is proven to be inadequate to identify elder mistreatment. And look at in primary care settings. Next slide. Multiple encounters. So look at it. Despite multiple encounters in primary care and mandatory reporting statutes, healthcare providers only made 11% of abuse reports, with physicians accounting for only 1% of that 11%. And what they identified was 5 major areas why they failed: professional orientation, assessment, interpretation. They don't know what the systems are there, what systems are there for them to report, and then knowledge and education. So I'm hoping all of you who work in primary care that you take this back to wherever you are. The next slide. I'm going to skip the next slide because of time. Can we move to next slide, which says why is dementia a risk factor? You're vulnerable to abuse because of memory impairment. You have problems with communication. You have compromised judgment. And as the dementia progresses, you're at risk for all types of abuse, all the different kinds. Next slide. And again, here are some additional risk factors. Low social support. You have functional impairment. You have poor physical health. Women are more likely to be abused. All of these kind of work in concert to put you at high risk when you have dementia. Next slide. And the victims are generally frail, physically and cognitively impaired, dependent on others for the care, whether it's a family member or a licensed facility staff. They are isolated. And for the most part, they're unable to report. Remember I said language, memory, all of that gets impacted. What can you do? Next slide. Listen to older adults who tell you about their suspicions. Do not discount an older adult's claim simply because they have cognitive impairment. Look for indicators and behavior change if they are having problems with communication, and ask questions if you are suspicious of abuse. Next slide. I'm just going to very quickly give you this data. This is the latest report I could get was 2017. Adult Protective Services conducted over 16,000 investigations. And 13,000 were from the community and about 6,000 were from the facilities. And next slide. And if you can look at it, the top kind of abuse in Oregon was financial exploitation, followed by all the rest. So top was financial exploitation. So my challenge to all of you, what kind of safeguards or guardrails do you have in your community for protecting older adults who are at risk for abuse? Because really our goal is, next slide, that elder abuse must become a cultural taboo. That elder abuse is a violation of human rights. And all of us on this training today should have zero tolerance for elder abuse. Next slide. And now I want to cover some resources. So next slide. So always start with the ADRC. That stands for Aging and Disability Resource Connection. And I've given you their website. It's quite easy to navigate, or you can call toll free to that number. The good thing about contacting the ADRC is that they have trained information and referral specialists who will be able to offer you a range of resources to the person or to the family member that they may not even have known existed or they qualify for. For instance, you may call about respite and you may learn that you are eligible for home delivered meals. So we are hoping that the ADRC is the one-stop shop, or what we call no wrong door, for family members or the person with dementia or professionals like you to enter into this system. Other services which they can offer are adult day services, and I've given you the link there. Adult day centers provide services to people who are disabled or confused or have memory loss. Participants socialize, eat nutritious meals, sometimes receive some basic health services like, podiatry, etc. And then they return home each night. You have to obviously qualify for it, or I think that you can also privately pay for it. But please check out that website. Next slide. At the ADRC, you have some staff called options counselors, and they offer what's called option counseling. The trained option counselor will meet with you and help you plan for the future on your own terms. They offer options. That's why they're called options counselors, based on what's important to you and your family. And it's free, totally free. It's not driven by insurance, and it's a very good planning tool. I've also included a handbook there for caregivers in English, but it's also available in Spanish if you go to that website. And then very quickly, I want to talk about Oregon Project Independence. Next slide, OPI. Sometimes you may have heard of it. Basically, if you're 60 and older and you live in Oregon, you do not receive Medicaid, because you're not eligible. You may be eligible for Project Independence, Oregon Project Independence. So it's really based on your income, and this is basically, they provide you with some minimal in-home care. But again, check it out through the ADRC. Next slide. Then we have, all of the wonderful virtual support groups. There are also psychoeducational groups that are available free from the Alzheimer's Association. Please check it out on their website. And yes, all of these groups, for the most part during the pandemic, have pivoted to virtual. I also want to bring this very good resource to your attention, Oregon Care Partners. It is free, high quality educational resource for families, for professional caregivers to build their knowledge and skills as they take care of their loved one or of their resident. Lastly, one more page of resources, the Older Adult Behavioral Health Initiative, which is I'm the project director of, and they are kind of co-sponsoring it with Rose and the Office of Rural Health. I've given you the website, and on the attachments you will see a list of their contact information. I've also given you the number for Adult Protective Services, the 800 number, and the technical assistance email for reporting abuse. Next slide is the Medicare wellness visit I talked about. I'm just giving you more information about the Medicare wellness visit if you're a provider, and what are the billing codes that you can use. And then next slide. This is also an attachment which Rose alluded to. This is kind of a workflow or a decision tree for when to do cognitive screening in your practice. You will get that attachment. And you know what? I have a whole bunch of screening tools attached, which you can take a look at. We don't have time to go over it. However, I have given my email at the very end. Rose, if you can just scroll through these. These are simple field tests, I call them, which anyone can do, like in your office. But if you want more information on any of the screening tests, here is my email. You're more than welcome to write to me directly to get information. So I know I kind of raced through it, but it's a lot to cover in 1 hour. I don't know, Rose, we may have a few minutes for some questions or comments. I'm happy to field them.
Excellent. Thank you so much.
Here is my email address. Anyone can write to me.
Great.
In fact, I love to hear from you.
Okay, so let's try to get a couple questions. You touched on cognitive assessments and said that you've included some in the resources. I will send out these slides to everybody. after we wrap up here. A question came in, what is the best tool to use for cognitive assessment? Is there one better than another, Normala?
So it really depends who you are. Through our initiative, we are promoting the SLUMS, SLUMS, which stands for St. Louis University Mental State. It's a longer test, 30 questions. MOCA is also a very good tool, but now you have to go through a little training, online training, and that costs about $125. So it's not totally free, but on the other hand, it's not exorbitant to get that training. So we are really advocating for that, but there are many other shorter tools which I've included, which unfortunately, if you write to me, I can talk to you about them. The clock drawing, verbal fluency test. So there are several others.
Excellent. Now, this is something that I've heard of a lot. What is the best way to deal with someone with dementia that is in denial of needing help? Any suggestions there?
So when you say denial of needing help, that means they are exhibiting symptoms like what, like wandering and in the early stages, when you have mild forms of dementia, there's a lot of what we call co-occurring depression happening because people know that something is wrong and they're kind of fighting it to make sense of it themselves. But as the disease progresses, one thing, and I know we all can't do it, there's not access for, is to really work with your medical provider to see, does my loved one have the capacity to be making these decisions? That I don't want this, I want this, because very often that decision-making ability does get impaired. And then sometimes you have to step in. Sometimes it's a legal matter. Sometimes it could be what we call surrogate decision making. You are making the decision on their behalf. But that's a tough one. I think I will need a lot more time to actually give you all the details on it. But suffice is to say, it happens all the time.
Mm-hmm. You reach out, send Normal an email and continue the conversation on that one. We have another question about data, data on risk of depression or other issues among CNAs caring for persons with dementia at nursing homes. Is this data that exists?
I know much of the data I shared was really family caregivers. I will have to look that up. I don't have it handy.
All right.
I always say kudos to our frontline caregivers in nursing facilities. We need to be doing a lot more for them. Aside from just recognizing the work they do, let's talk about giving them a living wage.
Yeah, no doubt. And you mentioned on your slide an increase in death during COVID for Alzheimer's. Any ideas as to why?
Not really, except that, people who were older were at higher risk. And especially in long-term care settings, that's where it was first, it really came in a wave in long-term. So it's the function of that. So it's not that Alzheimer's disease particularly puts you at a higher risk, but because many of the people in long-term care settings already have a dementia, there was a higher, death rate.
Great. Well, that really brings us to the top, and a couple minutes over. I'm putting the evaluation link into the chat box so that everybody can access it. I'll also follow up with you all at the end with these slides, with the attached resources. They're also here in the WebEx if you hover over the middle top of the slide deck on our screen here. I want to thank Nirmala. Nirmala, thank you so much for joining us today and providing that fast and furious oversight. There's so many kudos and thanks here in the chat and the Q&A. I think that you really helped a lot of folks out with a kind of a good, solid overview. Many thanks coming in, and we appreciate each and every one of you joining us today. If you have any questions, you can follow up with Nirmala. You can reach out to me. Thank you all so much for being here. Take care.
Thank you for inviting me. Take care.